Hello, I am Dr. Edhel Tripon, and welcome to the Hepatology Society of the Philippines webinar series. This module is entitled Caring for the Patients with Chronic Liver Disease. Viewers of this presentation will be given an overview of the monitoring of patients with chronic liver disease, as well as the process of diagnosing of progression to liver cirrhosis. We will tackle the care of the chronic liver disease patient, including those with compensated cirrhosis. Chronic liver disease may be diagnosed incidentally or deliberately. It may be detected by encountering abnormal liver blood tests or imaging. Incidental diagnosis in asymptomatic patients, more commonly non-alcoholic fatty liver or viral hepatitis, may be encountered in wellness checks in primary care. Diagnosing chronic liver disease can be important because with prolonged inflammation and cumulative fibrosis in the liver, you can get liver cirrhosis. Cirrhosis can be the terminal endpoint of any chronic liver disease. There are multiple causes of chronic liver injury, and the three that top the list in the Philippines are chronic viral hepatitis, particularly hepatitis B, non-alcoholic fatty liver, and alcohol. The etiology of CLD is commonly diagnosed through baseline liver tests and careful history taking, with special note of risk factors, family, and social history. Listed here are other less common causes of CLD that can be arrived upon on second-line testing. Note that there are instances when more than one etiology for CLD may be existent in a single patient. Finding the cause of liver disease may lead to administration of treatments that are proven to improve prognosis and even delay progression of disease. In both hepatitis B and C, antivirals should be considered. In fatty liver, judicious weight loss and treatment of components of the metabolic syndrome may improve disease. Alcohol abstinence can lead to the improvement of alcoholic liver disease, while in autoimmune hepatitis, immunosuppression may help. PBC or primary biliary cholangitis patients may benefit from starting ursodeoxycholic acid. Once the diagnosis of chronic liver disease is made, it is prudent to have a baseline assessment of the degree of liver fibrosis or scarring. For hepatitis B, a diagnosis of significant fibrosis may indicate the need to start antiviral treatment. For most etiologies, the most useful clinical endpoint checked by tests for fibrosis is the diagnosis of liver cirrhosis. The progression of CLD to liver cirrhosis will mean important changes in overall prognosis and increased mortality. Once the diagnosis of cirrhosis is made, the primary physician must change the mindset of management and proceed to screening and prevention of complications of cirrhosis. Cirrhosis is a diagnosis made through combining clinical and diagnostic findings. It is important to have a high index of suspicion in diagnosing cirrhosis in those with chronic liver disease and risk factors, as up to 40% of patients with cirrhosis are asymptomatic. The next few slides will review how we can arrive at the diagnosis of cirrhosis in the clinics with a combination of bedside examination and diagnostics. Liver biopsy is considered the gold standard for diagnosis. It is, however, an imperfect gold standard because it's not widely available and it involves risks that, although rare, are frequently unacceptable to most patients. Findings in the physical exam may lead us to suspect liver cirrhosis and perform the necessary diagnostic. Key findings that may be seen in cirrhosis include icteric sclerosis and jaundice, spider angiomata, gynecomastia, ascites, and collaterals that may manifest as caput medusae. A small nodular liver or hepatosplenomegaly may be palpated. In the extremities, you may get palmar erythema, Terry snails, clubbing, and muscle wasting may also be noted. And for the neuro exam in decompensated patients, asterixis and decreased cognition may be noticed. Various imaging studies, including an ultrasound, CT scans, and MRIs, can be used to help support the diagnosis of cirrhosis. In imaging studies, hepatomegaly or nodular small livers may be noted, and other findings include a widened fissure between lobes, increased left to right lobe ratio, as well as an enlarged caudate lobe. Splenomegaly, abnormal collateral vessels, an enlarged portal vein, and of course ascites may also be seen. Imaging findings of cirrhosis can be used in conjunction with abnormal blood tests. Abnormal liver blood tests can include thrombocytopenia, increased protime, increased bilirubin, and decreased albumin, which may be markers for hepatic insufficiency. Note that normal transaminases do not exclude the diagnosis of liver cirrhosis. Non-invasive tests for liver fibrosis are available. FibroScan, the proprietary name of vibration-controlled transient elastography, is a well-studied image-guided test for fibrosis. When image-guided fibrosis testing or elastography is not available, proprietary and non-proprietary blood tests, as listed, may be employed to assess severity of liver disease and the degree of fibrosis. Compensated cirrhosis is the phase prior to the onset of complications including variceal bleeding, hepatic encephalopathy, and jaundice. Prognostic scoring systems can help with determining prognosis and in identifying high-risk patients. All patients must also undergo screening for complications, and measures to prevent decompensation should also be instituted. The next few slides will discuss the goals of care in compensated cirrhosis. The initial evaluation may require an upper endoscopy for variceal bleeding, variceal screening, and labs can be done to compute prognostic scores like the child score or the MELD score. Baseline hepatitis serologies and an ultrasound or at least a baseline alpha-fetoprotein may be requested. Other tests may be warranted in other etiologies. Once esophageal varices are identified, the prevention of the first bleed should be considered. Consultation to determine primary prophylaxis, either with beta blockade or endoscopic rubber band ligation, may be considered. In the recent years, it has been proposed that there is a therapeutic window of benefit for beta blockers. Giving beta blockers too early exposes patients to the risk of beta blockade with little to no therapeutic benefit to them. On the other hand, if we give non-selective beta blockers to patients who have far advanced liver disease, you can worsen organ perfusion and even decrease survival in these patients. Beta blockers for prophylaxis may be warranted in patients with documented varices, as secondary prophylaxis also for those who have had previous bleeding. However, we should use them with caution and whenever we encounter them in patients with advanced disease, specifically patients who already have refractory ascites, hyponatremia, acute kidney injury or hepatorenal syndrome, spontaneous bacterial peritonitis, or episodes of overt sepsis. Screening for liver cancer. Various screening recommendations are available, but it will be prudent at this time to do at least serum alpha-fetoprotein and liver ultrasound, both widely available tests in patients with cirrhosis every 6 months. Early detection of liver cancer may lead to the diagnosis of patients in earlier stages, which may lead to possibly curative treatments like locoregional treatment for very small tumors, resection or transplant depending on the patient's current liver function. Vaccination. Immunity to vaccine-preventable hepatotropic viruses, especially hepatitis A and B, should be established at baseline diagnosis. Those with protective antibodies should be vaccinated. Without protective antibodies should be vaccinated, while other vaccines like the influenza and the pneumococcal vaccine should be advised to prevent infections that trigger episodes of decompensation. Avoiding hepatotoxic agents are part of cirrhosis care. Alcohol abstinence is best advised with the diagnosis of chronic liver disease. Progression of fibrosis is increased with continued alcohol intake due to the synergistic effect of alcohol with other causes of cirrhosis. In alcoholic cirrhosis patients, particularly, a 3-year survival of 65% can be had for those who remain abstinent or those who stop alcohol, while a 0% survival, 3-year survival, has been noted for those who continue drinking. In patients who need liver transplant, most liver transplant centers will require at least a 6-month period of complete abstinence from alcohol before patients are included in their liver transplant waitlists. Smoking cessation may also have value in decreasing fibrosis progression. All cirrhotics will need regular review of their medication list. Part of typical medications that need review are the following. NSAIDs are avoided due to the bleeding risk and the risk of kidney injury in patients who are already predisposed to kidney dysfunction. Paracetamol should also be used with caution, and if warranted, should be given only at doses below 2 to 4 grams per day. The indiscriminate prescription of proton pump inhibitors may need review due to some studies that indicate that PPI use may be correlated with increased risk of gut translocation and subsequent increase in spontaneous bacterial peritonitis and hepatic encephalopathy in cirrhotics. Metformin for diabetes can be used, but caution may be needed in decompensated disease. Herbal medications need special review because they are notorious for having undisclosed ingredients that may be hepatotoxic. Patients who need aspirin are monitored and advised regarding symptoms of bleeding. Statins, which are widely proven to decrease risk of cardiovascular events, can be started or continued in patients with liver cirrhosis unless drug-induced liver injury secondary to statins is strongly considered. In spite of the bad reputation and the overall risk of statin-induced acute liver failure is actually just at 0.2 to 1 case per million. For diuretics and antihypertensives, you just need to review their use due to the risk of acute kidney injury, especially in patients who are decompensated. Lastly, all chronic liver disease patients are advised to maintain healthy weights, and weight loss in overweight NAFLD patients serve as a cornerstone of treatment. Protein restriction in the diet is not advised, even in cirrhotics, as malnutrition is common in cirrhotics. A low-salt diet is advised for those cirrhotic patients who have ascites, and there is no need to restrict daily water intake unless patients already have hyponatremia or have other non-liver indications for fluid restriction. In summary, chronic liver disease is something that we frequently encounter both in primary care and in specialized sections. Diagnosing the etiology of liver disease may lead to early intervention that can prevent disease progression. There are many preventive measures that can be taken to avoid and delay complications in liver disease, and screening for complications, especially liver cancer, should be considered. The onset of liver cirrhosis should be monitored in all CLD patients. Thank you for watching.